Okay, hey guys, so this is the muscular system, chapter 18 in the Rosedale textbook. So let's get started. So we have three types of muscle tissue in our body. There's cardiac muscle, smooth muscle, and skeletal muscle. So cardiac muscle is found only in the heart. There are three layers around the heart. The middle layer is called the myocardium, and that's the actual muscular part of the heart. And the fibers that make up the myocardium are kind of short, they're branching fibers and they kind of fit together like a puzzle. It looks like it has stripes on it. That's called striated muscle tissue. And it's involuntary. In other words, you don't have to think about making your heart beat. It just does it on its own. So that's cardiac muscle. Then you have smooth muscle. Smooth muscle is found in your digestive tract, blood vessels, your bladder, your airways, uterus, if you're a woman. Skeletal muscle is not striated, and it is involuntary because it contracts automatically, like when you start to eat and food goes down your esophagus, peristalsis will occur, and that's where there are kind of a squeezing and letting go motion of the digestive tract that pushes the food down through the digestive tract. And then last but not least, you have skeletal muscle. That's attached to bones, and that's how we can move. It's very striated. When you look at it under a microscope, it's got really significant kind of stripes that look like stripes on it. And it's voluntary because it's not going to move unless we make it move. Okay? So three types of muscle tissue. The next slide is an actual picture, like a slice of a muscle tissue, skeletal muscle. So you see in the middle is the muscle fibers that surround it. There's this layer called the endomysium. And then around that, there's the fascicle with another layer of nerves. And then under that is the perimysium, which surrounds that, kind of keeps it together. And then at the very bottom, you see the fascia. And the fascia is what holds the whole lump of the muscle tissue together. And a tendon attaches to it. So when we think we want to move, skeletal muscle, it's voluntary. I think I want to stand up. My brain sends a message to my nerves. My nerves send a message to the tendon. The tendon sends a message to the muscles, and everything works together, and I stand up. But it happens at the speed of light. Okay, you don't even think about it. So skeletal muscle fiber, it's got bundles of fibers, and most of the fibers are about 1 inch and 1/5 inches long. They're very delicate tissues around that endomysium, and they're grouped together in bundles that are called fascicles. Like I talked about earlier, the tougher layer is the perimysium around it. And then the top layer of all of it, keeping it all together, is the epimysium. So for A&P purposes, make sure you know the epimysium is the most outermost layer, then the perimysium, and then the endomysium. And you can remember it because endo means inside or within, okay? Then there's connective tissue around the muscle that's called fascia. Okay. The deep fascia lies between muscles. Superficial fascia is your hypodermis. So if you think back to when we looked at skin, integumentary, that's what that is. And that's just underneath the dermis. Okay. So we got our three classifications. And so we separate classifications of muscle separated by either function. So it's either skeletal, smooth, or cardiac, or we can separate it by whether it's striated or non-striated. Or we can separate it by whether it's voluntary or involuntary, right? So now let's talk about muscle contraction. And this is important to understand because it involves a neurotransmitter called acetylcholine, okay? So if you look at the slide with the side slice of muscle tissue, what you'll see if you look down in the bottom, you see those little finger-like structures. So they are ACH receptors, acetylcholine receptors. So what that means is when we think, oh, I want to move, then acetylcholine, a neurotransmitting chemical, gets released and attaches or binds to those receptors, right? And then the brain sends the signal, move your arm or move your leg or stand up or whatever it is you're doing. A lot can go wrong. And we'll learn more about that when we get to med-surg, because sometimes there can be a disconnect between the brain sending the signal or vice versa, okay? So just know the ACH receptors are the things that where the acetylcholine binds to, and that's what allows the nerves to talk to the muscles. There's a disease called myasthenia gravis, and I call it ragdoll syndrome. Why? Because when you have it, your acetylcholine receptors cannot receive acetylcholine. So in essence, it's like having no acetylcholine. So you have no voluntary muscle control. You're just like a rag doll. Okay. So skeletal muscles, they're voluntary, they're striated, they control all your skeletal movements, they're consciously controlled by us. And there's more than 630 muscles in our body. And if we wanted to break it down even more, we could break it down by fast twitch or slow twitch. People that are really into like the gym and working out will talk a lot about fast twitch and slow twitch muscle fibers and how you need to work both of them in order to build muscle mass, because they have memory. There's something called muscle memory. If you do the same repetitive action all the time, let's say you work in a factory and your job is to do the same, I'm doing this all day long. You don't even really have to think about it. It almost becomes involuntary. So there is a part of a memory almost, not like the way the brain memorizes, but just from that repetitive action that you're doing over and over again, those voluntary muscles will go, oh, I know what she's doing. And they make it a little bit easier for you to do whatever that task is. Smooth muscles, they're the involuntary ones. Like I said, the big ones are your digestive tract, your urinary tract. Also, they're the ones that dilate your pupils. Okay. And they activate the erector pili. Everybody remembers that's the goosebumps, right? So those are the muscles that activate that to make the hair stand on end. They also control blood pressure. So when we say they control blood pressure, they help to control blood pressure. Depending on how much fluid you have peripherally, the smooth muscles can constrict or relax on the blood vessels, the arteries, which can, if they constrict, blood pressure is elevated. If they relax, blood pressure comes down. So they play a role in blood pressure management. They can respond to nervous stimulation in an emergency. So in other words, typically these are involuntary, but let's say you ate some bad sushi, right? And your stomach's starting to go, and starting to feel queasy, right? That stimulation from the nervous system is part of what makes you vomit, right? And it's the body's way of saving you because that sushi was bad. And your body's like, we don't want this in here. You need to get rid of this, okay? And then the fight or flight response. So when we get to the neuro system, we'll talk about that. If you're scared or anxious or nervous about something, there's an involuntary mechanism that we have in our body, and we call it the fight or flight. It's the sympathetic and the parasympathetic nervous system. And the sympathetic nervous system is the one that says when the brain goes, I'm nervous, we're in trouble. For whatever reason, you're anxious. The body responds by releasing a flow of norepinephrine, which is another neurotransmitter. When that norepinephrine starts to flow through your body, it's like adrenaline. What'll happen is your pupils will dilate to let more light in so you can see whatever. This is going back to our caveman days, right? When we could have gotten eaten by a bear or something, right? So when we felt scared or nervous, our body was going to help us out. Pupils dilate. If you have food in your digestive tract, the blood flow to the digestive tract will stop and it will get diverted to your arms and legs in case you got to fight or run. I mean, it's really amazing. And, the hairs on the back of your neck will stand up, just that whole, like, I'm ready response. And you can't make that response stop voluntarily. The only way that response stops is when your brain says, okay, the threat is gone, or when you've burned off that norepinephrine, like you either fought with the bear or you ran away from the bear or whatever happened, right? Cardiac muscle, involuntary and striated. And again, 3 layers around the heart. It's the middle layer, and it's the actual part of the heart that squeezes the inside chambers of the heart to make the blood pump, right? Because the heart's just a pump. And that's automatic. You don't have to think about your heart beating, okay? The control center for all of these things, your heart rate, your blood pressure, and your respiratory is all at the base of the brain, at the medulla oblongata and the pons in the base of the brain. And that's all involuntary. So here's another cross section of skeletal muscle. And you can see what I talked about earlier, the epiphysium, right? There's the tendon's connected to it at the end. And you can see where the muscles will stretch to pull. Like, let's say you want to pick something up. They'll contract and then they'll relax, right? Think about what your muscles can do based on what you want them to do, because this is all voluntary. You have a lot of muscles in the body, like I said, around 630, give or take. Some of the muscles are bigger than others. Your diaphragm, which is a big muscle that runs underneath your lungs right here, is the one that has to, when you inhale, it goes down. When you exhale, it goes up. And then you have intercostal muscles that help your rib cage expand and contract. Again, focused on breathing, the ability to breathe. And then the muscles in your hands, think about everything you can do with your hands. They're amazing. And your feet, right? Carrying all that weight of you. Not that you're heavy, but. So there is 2 pictures of the major muscles of the body. And you can see they're all named. Now, do I expect you to know all of them? No. But I do expect you to know some of them. So you should know the diaphragm. You should know the intercostals. Okay. You should know up at the top, if you look at the anterior view of the little man, the sternocleidomastoid, which is right here. Okay. And then the trapezius, these guys right here. The reason they're important is because people that have breathing difficulties, for example, people with chronic obstructive pulmonary disease, you will find that for us, we just breathe. For them, sometimes they go, or they lean forward. Right? And you'll see them using all these other muscles to help them breathe, right? So you need to know about those muscles. The other muscles you need to know about, if you look at the leg, please tell me that, yeah, the vastus lateralis. Okay. Look at the thigh. And third from the bottom left, third up from the bottom left is the vastus lateralis. You see where it is in the thigh? Why is that important? Because that is the site for intramuscular injections for babies up to 1 year of age, give or take. Okay. We don't give them in the deltoid, which is back here, like we do with adults. Adults, IM injections are given in the deltoid or ventrogluteal. Infants, it's given in the vastus lateralis. So that's an important one to know. And then back up, can we see the deltoid? Yeah, if you look at the posterior view of the little man, and on the right-hand side, it is the 4th one down. You'll see the deltoid. People sometimes get confused with these muscles. So the bicep and tricep here and here, the deltoid is up high. It's here. Okay. So when you go get your flu shot, that's where they're supposed to stick it, in the deltoid. So know the deltoid, know the bicep and the tricep. And then, let's talk about the gluteus. You have several muscles in your buttocks. Okay. When we give an IM injection to an adult, if it's a large amount that has to be injected, that's a larger muscle. So you want to put that needle into a larger muscle. The easy way to do it is you take your hand like this, and on the patient, you put your thumb on their iliac crest, which is the hip bone, right? I'm going to do it upside down to show you, right? But on a patient, it would be this way. Right here, and between these 2 fingers, your first and second, that's where you would hit the needle. That is the ventrogluteal, okay? So if you look on the chart, the little man chart, you can see you have the gluteus medius, which is really what it is. And then ventro means the gluteus medius towards the back, right? Ventral towards the front, rather. Okay, do you see that? So that's on the left-hand side of the little man, the posterior view. 1, 2, 3, 4, the 5th one up, gluteus medius. Okay. And as far as knowing the muscles, they're the ones that you should know. Don't worry about all the rest of them. I'm not going to expect you to memorize all of them, but know the ones that we just went over. All right. So muscle contraction. So your nervous system controls your muscles, right? For your voluntary muscles anyway. When a muscle contracts over and over again, several times in a row, and the last contraction is stronger than the first, that's called trepi. And I should have highlighted that. That's important, trepi. So when the impulses reach the muscle fibers even faster, the fibers don't have a chance to relax completely before the next stimulation or impulse comes along. So what'll happen is the condition of these rapid contractions is called incomplete tetanus. If you've ever seen anybody with, say, multiple sclerosis or Parkinson's, and they have, see tremors, what's happening is the nerves are sending signals and they're just going too fast. So the muscle doesn't have a chance to recover from the nerve impulses. The nerve sends an impulse, so the muscle, and then relaxes. But before it has a chance to relax, the next impulse comes. So they're coming so quickly that you see the tremors, right? Isn't that fascinating? And then if it comes so fast that they just kind of all merge together into one prolonged contraction because those nerve impulses are going boom, 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 boom. That's complete tetanus. And that can become muscular rigidity. So people with, say, Parkinson's disease, the reason that they die is because they go into complete tetanus to the point where the intercostals and the diaphragm cannot expand and contract appropriately. They're just in such complete tetany that they're rigid and they can't take a breath. So they die from respiratory arrest. Okay. So the strength of the stimulus dictates what the muscle does. So the stronger stimulus will excite more of the nerve endings, right? And will excite more of the fibers in the muscle. And then you'll have a stronger contraction. Think about if you have to lift something heavy, right? And you get psyched in your head and you're like, all right, I'm going to lift this heavy box. And you bend appropriately at the knees and you go down to lift that heavy box. When you go to lift it up, what you're doing is you're recruiting. That's why it's called recruitment. You're recruiting as many of the muscles in that group as you can to lift that, whatever that thing is that you're trying to lift. Okay. And then we'll talk about isotonic and isometric. So isotonic contractions is where the muscle actually changes shape, right? It lengthens, it gets longer and shorter. So it moves something, it moves a load. Okay. In isometric, the tension within a muscle increases, but the length doesn't change. Give you an example. If you're at a gym and you're lifting weights, you're taking the weight, right? The muscles are changing shape. If I'm sitting here and I just tighten my abs, that's isometric. So they're not changing, they're not lengthening or shortening, but you're tightening them. So that's isometric. So know the difference between isotonic and isometric. Okay. All right. Next, we'll talk briefly about tendons and ligaments. Ligaments are first. Ligaments are tissue that connect the bones and hold them in place. They let your joint move the way they're supposed to move. They hold your bones together. They make sure that like your shoulder doesn't dislocate because your shoulder, think about it, is a ball and socket joint. It can do all kinds of stuff, but the tendon or the ligaments are kind of holding it in place so it doesn't just fall out of the socket. Your knee has 4 ligaments in it. When you hear like a football player got injured and he injured his ACL, anterior cruciate ligament, those 4 ligaments in your knee, they do a lot of work. Think about your ability to bend down, squat, right? Those kinds of things. They keep everything in that patella, the knee, together. And they also connect your liver, intestine, and stomach to the wall of the peritoneum inside the abdominal cavity, and they hold all that stuff in place. Otherwise, your stomach would be just plopping all over the place. Tendons attach muscles to bones. So they are like cords. Think of them like rubber bands. Okay, that's the best way to remember a tendon. A tendon is more like a rubber band. My husband had a bicep tendon injury and it was hysterical, but it wasn't for him, but it was for me. So when you make a muscle and you can see the bicep, his bicep, the tendon here connects from the end of the bicep to the ulnar. It snapped. His bicep went bloop, and it was down here. Was the freakiest thing you'll ever see. So I was like, look at you. Can't have surgery, have it repaired. But that gives you the idea. So it's like a rubber band. And if it snaps and breaks, nothing's holding the muscle where the muscle's supposed to be. So that's why it just went bloop, right, and moved. It allows for gliding movement of the muscles and the bones. There's a nice picture, the next slide. Each end of most of your skeletal muscle adheres to a different bone, right? And the contraction of the muscle makes the bone move. Like I said, if I want to stand up, my brain sends the message and I stand up. If you look at the arms, one of the tendons moves and the other one won't. So one holds it in place and one lets it stretch to move. Okay. So that's basically how we're able to move the way we are. It's actually question 1. Is the following statement true or false? Ligaments attach muscle to bone. No. And here's a nice little thing to help you remember on the next slide. Bone to bone equals ligament. Bone to muscle equals tendon. Bone to bone is ligament, bone to muscle is tendon. And if you look, it says B2B equals L and B2M equals T. So in other words, the letters, it's going like in alphabetical order. And that's a way for you to remember what's what. Muscle contractions. Muscles they have contractility, and that gives them the ability to shorten and lengthen and become thicker. Extensibility, that's the stretching. Elasticity, they are very elastic. They can return immediately back to normal after you stretch them out. And the irritability doesn't mean they're in a bad mood. It just means that they're able to respond to the impulses of the nervous system. And they pretty much operate under the all or nothing principle where, when you are when your brain sends a signal to make something move, it's either moving or it's not. Like it's sometimes difficult to make smaller moves, and they don't respond without some kind of stimuli, whether it's internal, your brain telling it to move, or just think about if you are near something hot and your hand is going towards like a hot stove and you pull it away. Okay. We talked about that a couple classes ago. Now, acetylcholine, right? That neurotransmitter that I was talking about. So there's a neuromuscular junction. That's the junction. That's the little connection, like a bridge that's between the nerve and the muscle. And in there's a little space where those little finger-like things were with the acetylcholine receptor sites. So this is the way it happens for the muscle to contract. Your brain thinks, I want to move my arm. So that's the impulse. The impulse reaches the motor neuron and it causes those little vesicles to fuse with the cell membrane. And then that acetylcholine goes and gets released. The acetylcholine sends, it goes across and it stimulates those receptors, those little finger-like things we saw. And that sends an electrical impulse through the fibers. And you don't need to know about the T-tubules and how the T-tubules cause the sarcoplasmic reticulum to release calcium. The calcium binds with troponin. You don't need to know all that, but you just need to understand that without the acetylcholine, none of that process is going to happen. The acetylcholine is the chemical that's necessary for all of those things to happen for the muscle to move, for it to contract, okay? And I'm not going to get into abductors versus adductors. So different muscles in the body will do different things and let different bones move in different directions, right? You have a complex group in your shoulder, very complex group. Because of all the joints in your body, your shoulder has the most movement ability. It can pretty much go anywhere you want it. Your hip's a ball and socket joint too. But unless you're a gymnast or like you're really like double jointed or something, you're not going to be able to do with your leg what you can do with your arm, with that shoulder joint, right? The power source. What's the energy to make this happen? Look, glycogen, sugar, lactic acid, and ATP, right? So when we feed our cells the carbohydrates, the cells make the adenosine triphosphate, that energy, in addition to the glycogen and the lactic acid that all work together with the acetylcholine and the calcium and sodium. There's a sodium potassium pump. It's a complex system that's amazing. I can't say it enough. It's amazing. And all of that has to work just right for you to move your muscles. Okay? Just right. And here's a fun fact. Have you ever heard anyone say, well, when you go to the gym, you got to do it till it burns. Do it till it burns. Work those muscles till they burn. When you're working your muscles till they burn, your muscles are going into anaerobic activity. That means that you've been working, and now there's no more oxygen left. When they start working anaerobically without oxygen, they produce lactic acid. That lactic acid, it's acid, it burns. That's that burning sensation. Sometimes you feel like it's just burning on the inside. That's what that is. Here's another thing about the isometric and isotonic. So remember, with isometric, there's no length, no real movement. It's just tightening the muscles. Like I'm just sitting here and tightening my abs. Isotonic is where there's movement involved. The muscle is getting shorter and thicker, causing movement. And then aerobic and anaerobic. Aerobic, think about aerobic exercise, running, jogging, bicycling, spinning, any of those things. You need oxygen, right? So it's using oxygen, but oxygen there will only last so long. Okay. Anaerobic, that's where your fast twitch muscle fibers start to get used. And that's where you start to feel that burn. This PowerPoint talks a little bit about rehabilitation. So physical therapy, when you want to remember physical therapy versus occupational therapy, physical therapy deals with ambulation, transfers, think lower body, right? Those kinds of things. Whereas occupational therapy deals mostly with upper body, ADLs, brushing your teeth, washing your face, washing your hair, right? Eating, those kinds of things. Okay. So that's the difference. People that say have had a massive CVA, cerebrovascular accident, which is a stroke, they need rehab because often there's so much damage because of that ischemia and the nerve damage to their body that they need therapy. I always tell people when you're working, if you're a CNA or a home health aide, don't deadlift patients. Don't do it because you will get hurt. It's dangerous for the patient too. You really have to be conscious of taking care of your muscles and your body, especially in this line of work, because you're going to be doing a lot of moving, right? A lot of moving of people. So you want to make sure that you're using the proper body mechanics. Don't ever bend over and try to lift. You always do a squat, right? Use your legs to lift, and always keep your legs at least hip distance apart, right? You don't want your feet close together. That's going to put a strain on your lower back. And if you don't want a back injury because they stink. Okay. I'm going to just say objectively or subjectively rather, I disagree with what they're saying on this page, but I'm going to read it anyway. So this talks about the effects of aging. Okay. It says bone mass and strength are lost. Not if you keep moving. They don't have to be, right? They can be, but they don't have to be. Calcium is lost. Again, they don't have to be, but it can be. The vertebral column does shorten. Hey, people will get shorter as they age. Some people get really shorter as they age. Some people just lose a little. I mean, I was 5'6.5" and I'm 5'6", so I have lost like a half an inch. Not so bad, but still. Degeneration in the joints, wear and tear, the knees, the hips, right? From over and over repetitive movements. Muscle cells get replaced by fat. Not if you keep using them. It's important, especially for women, to develop muscle tissue before menopause. Because if you're going to try to develop it after menopause, you're going to have a hard time, right? For multiple reasons that we'll get into in other video lectures. But you have to prepare for that stuff before menopause. So this way, when menopause comes, and it's a good time, let me tell you, you'll have such fun. When it comes, you don't get weak. Because then they're the ones where they go to the hospital because they fell and they couldn't get up, right? You don't want that to be you. And that's why they have an increased risk of fractures. And sometimes the immune system slows down, healing process slows down. All of these things are potentially may happen with aging, but they don't have to if you stay in shape and try to take reasonably good care of yourself. Range of motion. I'm just going to explain active range of motion and passive range of motion. Active range of motion is where I am moving my own body parts, right? So I can flex, extend, right? If I can't, for some reason, do it myself, then the aide or the nurse will come in, support the joint, and then move it for me, right? So that's passive range of motion. That's where someone else is doing the moving for you, for the patient. Okay. So the question here is range of motion exercises are only important for individuals with musculoskeletal injuries. If you said false, you would be right. It's important for you to stay in shape. Everybody stay in shape. Definitely people that have had things like strokes, they need that kind of exercise. But range of motion, even if you're not really, really heavy into the activity, you want to at least do stretching and do some things to keep everything moving so that you don't have pain. And that's the end of the A&P lecture for muscles. The end. Stop share and say bye.